Kawasaki disease. Key points. Kawasaki disease, KD, is a clinical diagnosis that requires prompt recognition and management. Consider incomplete KD where there is prolonged fever and no alternative cause found. Infants and adolescents may present with incomplete KD and are at particularly high risk of developing coronary artery aneurysms. Early treatment with intravenous immunoglobulin, IVIG, has been shown to reduce morbidity and mortality. Background. KD is the second most common vasculitis in childhood after Henoch-Schönlein purpura, and is the most common cause of acquired heart disease in children in high-income countries. Lack of appropriate treatment leads to coronary artery aneurysms, CAA, approximately 25% of cases. Worldwide distribution, although more common in Asian children. Approximately 75% of cases occur under 5 years of age. Less common in children and LT 6 months and GT 5 years, however these children are more likely to develop CAA. Can present without all diagnostic criteria, see flowchart below, which can present a significant diagnostic challenge. Assessment. History. Physical findings can present sequentially over a number of days, thus history should include asking about diagnostic features that may have resolved by the time of presentation. Examination. Kawasaki disease, diagnostic criteria. Fever persisting for 5 days, plus 4 of the 5 following criteria. A diagnosis earlier than 5 days can be made with a typical presentation in consultation with an experienced clinician. KD can be diagnosed with less than 4 of the following features if coronary artery abnormalities are present. Criterion. Features. Conjunctival injection. Bilateral, non-exudative, painless. Often with limbic sparing, zone around the iris is clear. Rash. Erythematous polymorphous rash occurs in the first few days, involving trunk and extremities. Variable presentations, most commonly maculopapular, erythema multiforme-like or scarlatiniform. Bullous, vesicular, or petechial rashes are not typical in KD. Oral changes. Strawberry tongue. Erythema, dryness, cracking and bleeding of the lips. Diffuse oropharyngeal erythema. Exudates are not typical of KD. Extremity changes. Hyperemia and painful edema of hands and feet that progresses to desquamation from the second week of illness. Lymphadenopathy. Cervical, most commonly unilateral, tender. At least one node and GT 1.5 cm. Less common feature and seen in older children. Photographs used with permission from the Kawasaki. Common findings in addition to the diagnostic criteria include neurological, irritability, aseptic meningitis. GIT symptoms, abdominal pain, vomiting, diarrhea, gallbladder hydrops. Arthralgia/arthritis. Dysuria. Inflammation at recent, within 6 months, BCG vaccination site. KD is a medium vessel vasculopathy, any organ system can be affected. Incomplete Kawasaki disease. Consider in a child with a clinical presentation suggestive of KD but not meeting the full diagnostic criteria. Requires abnormal investigation results to support the diagnosis, see flowchart. Infants and adolescents often present with an incomplete picture and are at a higher risk for cardiac complications. Consider incomplete KD in a child with fever for at least 5 days combined with 2 or 3 of the principal clinical features or an infant with 1/more of the following features. Fever greater than or equal to 7 days plus/irritability without other explanation. Prolonged fever and unexplained aseptic meningitis. A child or infant with prolonged fever and shock. Cervical adenitis not responsive to oral antibiotics. Incomplete KD can present a significant diagnostic dilemma, however once the diagnosis is made, the treatment for KD and incomplete KD is identical. Incomplete Kawasaki disease. Adapted from the American Heart Association, 2017. Differential diagnosis. Group A: streptococcal infections, tonsillitis, scarlet fever, acute rheumatic fever. Viral infections including EBV, CMV, adenovirus, HHV6, SARS-CoV-2. Systemic juvenile idiopathic arthritis, CHIA. Sepsis. Toxic shock syndrome, staphylococcal or streptococcal. Stevens-Johnson syndrome. Drug reaction. Malignancy. Management. Investigations. There is no diagnostic test for KD. Laboratory tests provide support for diagnosis, assessment of severity, and monitoring of disease and treatment. Echocardiogram. Discuss with cardiology-specific timing of initial and follow-up studies. At presentation, 2 weeks, 6 weeks. Coronary artery lesions should be managed in consultation with pediatric cardiology and hematology services. In all patients consider FBE, CRP, ESR, UEC, LFT. Note ESR result unreliable after IVIG administration. Blood culture, ASOT. Serum to store, prior to IVIG administration. Urinalysis and culture, sterile pyuria. Blank. ECG. Common abnormalities include elevation of ESR, CRP, and neutrophils. Thrombocytosis is common in the second week of illness. Treatment. Intravenous immunoglobulin, IVIG. 2g/kg as a single 4 infusion on diagnosis. IVIG should be given within the first 10 days of illness but should also be given to children diagnosed after 10 days if there is evidence of ongoing fever and/or inflammation. A second dose of 2g/kg IVIG should be given to children who do not respond to the first dose, as demonstrated by persistent or recurrent fevers 36 hours after the end of the first IVIG infusion. Seek specialist advice. The National Blood Authority and BloodStar coordinate and authorize the use of blood products. IVIG is a product that must be ordered via their Hemolytic anemia is an uncommon but recognized adverse effect of IVIG infusion, particularly for children receiving multiple doses. It typically occurs up to a week after IVIG administration. Post-IVIG vaccination, live vaccines, e.g. measles and varicella, should be deferred after IVIG administration. If the child is at high risk of measles, vaccinate and revaccinate after the appropriate period. Aspirin, 3-5 mg/kg orally as a daily dose until normal echo on follow-up, minimum 6 weeks. There is minimal risk of Reye syndrome with low-dose aspirin. Avoid non-steroid anti-inflammatory medications whilst on aspirin. Corticosteroids. Evidence for indication and optimal dose/duration of adjunctive steroids in the primary treatment of KD is limited. Corticosteroid use in KD should be considered in consultation with specialist advice. Consider use in high-risk groups which include demographics, age and LT 12 months of age, Asian ethnicity. Investigation abnormalities, ALT and GT100 IU/L, albumin less than or equal to 30 G/L, sodium less than or equal to 133 mol/L, platelets less than or equal to 30 x 10/L, CRP and GT100, mg/L, anemia for age. Cardiac or coronary artery involvement on echo at presentation. Additional treatments. A number of therapies are available for consideration in patients who are not responsive to initial IVIG. These options should only be used in consultation with local pediatric specialists and include biological medicines such as infliximab. Consider consultation with local pediatric team when Kawasaki disease is suspected. Child does not respond to initial treatment. Consider transfer when child has cardiac involvement or timely echocardiography is unavailable locally, in consultation with the pediatric cardiology team. Children requiring care above the level of comfort of the local hospital. Consider discharge when afebrile and well at least 36 hours after treatment. Children are on a daily dose of aspirin, See treatment point 2 above. A follow-up plan is in place including general pediatric review and repeat echocardiograms planned with cardiology.